Okay, let's get going then, as I think more people might join us, but great to see so many of you here. So just a little bit of a caveat about this presentation and what we're going to go through as a topic. For people who may have gone to the in-person UK Kidney Association Network meeting last month in May, I think it was. So Rosie and our colleague Francis did present some of this information there as well. So if you did go to that, some of this might be familiar to you, but hopefully, you know, it'll either be a good refresh or, you know, not everyone was there. So we're going to go through it again. So just kind of a little bit of background and stuff that I'm probably sure that you're all aware of. But when we're thinking about improving overall sustainability and delivering net zero goals in the NHS, transforming care pathways is really a crucial part of that, and decarbonising healthcare services. And when we're thinking about this from a kidney or patient pathway, from the onset of kidney disease through to, someone's just got their microphone on, through to kind of the point of when someone's needing a transplant or needing that more intensive treatment, dialysis. Obviously, as that disease progresses, more and more interventions are required and more treatments are required for someone. And that all comes at a cost to the patient in terms of what they have to go through and their own health, but also in terms of resource use. We know that within kidney care, dialysis is a key carbon hotspot in terms of energy, water use. It generates a significant amount of consumable waste and travel emissions. And when we're thinking about applying the principles of sustainable clinical practice, the more we can do upstream to prevent people getting to the disease or early detection and empowering people to kind of manage the condition in the first place, that's the most effective thing we can do. And we know kidney care the kidney care community has spearheaded a lot of the work in sustainable healthcare over the years. And a lot of work has already been done across this pathway to really understand the impacts from a sustainability perspective. But there's always more we can do and improvements that can be made. And at CSH and along with colleagues in the UK Kidney Association and NHS Blood and Transport, we were keen to look at areas of the pathway which could be improved, and also where there are considerations around equity. So CSH, along with partners from NHS Blood and Transport, the UK Kidney Association, and with funding from the Health Foundation, developed a project initially to review the living kidney donor pathway and understand where the environmental and equity impacts and hotspots are, and then explore the potential to redesign, ultimately thinking about reducing the time to transplant, increasing access for people, and reducing its environmental and financial impact. So that's just kind of the background of why this project's important and how it came about. So the project has really been in two phases. The first phase was a 3-month initial project, and that was to map the carbon and equity hotspots in the living kidney donor assessment pathway, exploring potential areas for improvement. And we're going to run through the findings of that first phase now, briefly. Then the second phase is really what we're all here today for as well, is to disseminate the findings of that, and then to develop a toolkit and support for people to be able to map their own kidney donor assessment pathway, to think about where improvements could be made, resource use could be saved, and things could be improved for donors and from a sustainability perspective. So this is the abstract from the initial project, and I'll just run through this very briefly, but essentially the aims were to ensure that the living kidney donor assessment pathway is mapped. There were 3 sites that were included, and wanted to understand what some of the variations across those sites were, and because it's known that there are quite a lot of variations in how the pathway works across different sites. Understand sources of social impact and inequity, ensure that the environmental impacts of the pathway were calculated, and then the findings were presented and collective community goals were agreed across services. So as I say, 3 transplant centres were mapped, and these were contrasting centres, so we wanted to look at the differences between urban and rural sites and where there were transplant and non-transplant centres, and that was done with input, a huge amount of input from staff and people with lived experience of donation as well. And then the carbon impact and demographic data was reviewed and lived experience interviews were conducted as well. And then just in terms of the results, that's what we're going to go through now, really. But just to say, the average assessment pathway was calculated in terms of its carbon impact. And then Rosie's going to talk a little bit more through that now. So I'll pass over to you, Rosie.
Thanks, Kath, and you can move to the next slide. Thanks. So yeah, we set out to carbon footprint the living kidney donor assessment pathway at each of the 3 sites. So for each site, we mapped out the contacts as well as the tests and diagnostics undertaken at each of those contacts, and then any other resources such as energy and water consumption during the face-to-face contacts, donor travel, staff commuting, and then the transportation of any bloods and tests to external labs. The table on the slide shows an example pathway analysis. It's quite small, but I'll go through the detail in a couple of slides' time. It's just to kind of give you an example of the mapping process that we went through. So you can see all of the activities down the left, and then all of the contacts up the top, and then the carbon footprint of each activity mapped to each contact in the middle. So we basically had a spreadsheet like this for all 3 of the sites, but for site A, they had recently revised their pathway. So we looked at both their previous pathway and their new pathway. And next slide, Kath. In terms of methodology, we used a hybrid approach to calculating the carbon footprint associated with each of the resources. The table on the slide gives a very brief overview, but just another big shout out to all of the sites that were able to provide us with data, so we could use that for the carbon footprinting, because without them, the project wouldn't have been possible. So going very briefly through the table, for donor travel, for site A and C, we were able to use a sample of donor postcodes to get an average mileage per contact. But for site B, we used just some averages, an average postcode distance in the region to the hospital using Google Maps. For staff commuting, again, for site A and C, we were able to use a sample of staff postcodes, but for B, we extrapolated data from a national decarbonisation strategy. All sites were able to provide us with site-specific data on the transportation of bloods to labs, which was great, for electricity, gas and water used at the appointments. We were able to get some site-specific data on annual energy consumption for site A and B, but for site C, we estimated this based on site B. And then for all the blood tests, diagnostics and urine tests, we had quite a short timescale for the project, so it wasn't feasible for us to carbon footprint all of the tests from scratch ourselves. Instead, for a few of them, like the blood chemistry, hematology and x-rays, we were able to take data from published articles. But for those tests that hadn't already been carbon footprinted, we either extrapolated data from the articles or we looked at using financial cost instead. Next slide, Kath. And you can skip this one actually. So this table shows the carbon footprint of each contact at each site, as well as the total carbon footprint for an average typical donor going through the assessment pathway. So the carbon footprint is expressed in kilograms of carbon dioxide equivalent. So just running through this very quickly. So site A, their previous pathway, they had 12 contacts and their total carbon footprint for the pathway was estimated to be 112.9 kilograms of carbon dioxide equivalent. Site A's new pathway, they reduced it down to 8 contacts and their total carbon footprint was 92.3 kilograms of carbon dioxide equivalent per donor. Site B, they had 7 contacts and their total carbon footprint is estimated to be 139. And then site C, they had 5 contacts and their total carbon footprint was estimated to be 111.3 kilograms of carbon dioxide equivalent per donor. In terms of why the carbon footprint varies between sites, firstly, donor travel has a big part to play in the total carbon footprint. So for site A, donors were able to have a lot of their contacts at their local hospital, and only a few of the contacts needed to be at the larger regional hospital. So they had less travel emissions for a couple of those contacts, whereas the transplant centre in Site C served a much larger area than the other sites. So although they only had 3 face-to-face contacts, and they streamlined their pathway quite a lot, for those face-to-face contacts, they did require all of their donors to travel to their main site. So on average, they had a lot further to travel. And then secondly, the number of contacts can also play a role in the variation. So you can see by site A, reducing their number of contacts from 12 to 8, they managed to save 20.6 kilograms of carbon dioxide equivalent per donor. Next slide, Kath. So this slide shows the carbon hotspots per living kidney donor assessment pathway at each of the sites. And actually, the hotspots are the same across each of the sites, but it's just the contribution of each hotspot that varies. So as you can see from the pie chart, donor travel, which is the light green segment, that contributes the most to the total carbon footprint of each pathway, each site. So it ranged from 54% at site A, 69% at site B, and then 61% at site C. Greenhouse gas emissions associated with blood and swab tests were the next largest contributor to the total carbon footprint, and actually all 3 of the sites had very similar emissions for blood and swab tests. Site A and C were estimated to be 18 kilograms of carbon dioxide equivalent, and then site B 21 kilograms. And then thirdly, the greenhouse gas emissions associated with diagnostics were the 3rd largest contributor, ranging from 5% to 8%. And again, all 3 sites had very similar emissions for the diagnostics. Next slide, Kath. Looking at the average carbon footprint across the site, so excluding site A's previous pathway, we estimated that the carbon footprint for an average living kidney donor assessment pathway to be 114.2 kilograms of carbon dioxide equivalent per donor. What does this actually mean? So in terms of whether that's large or small, just to put it into context, it's the equivalent of driving 337 miles in a petrol car. So like driving from Edinburgh to Glasgow 6.5 times. And again, the pie chart just highlights that donor travel is the top carbon hotspot. Next slide, Kath. And then lastly, as we mentioned before, we estimated the carbon emissions of site A's previous pathway as well as their new pathway. So you can see the results on the slide, and by reducing or condensing their appointments, they managed to save 20.6 kilograms of carbon dioxide equivalent per donor. And yeah, majority of these savings were associated with donor travel, as they managed to condense their tests into fewer contacts, so less trip for donors. Back to you, Kath.
Thank you, Rosie. So just a little bit of brief information about how we considered equity and lived experience through phase 1 of the project. So what we tried to do with the 3 sites is a bit of understanding of their caseload. So we asked the 3 sites to look at a 12-month data period of kind of data points between 2023 and 24, and look at numbers entering the caseload, the numbers that then went on to donate, and some demographic information about caseload, so age, ethnicity, and reasons for dropout, non-completion. Unfortunately, it was a really short timescale project, and so we weren't able to collect all the information, or the information wasn't readily available around the caseload. So it's something to consider, I think, when you're thinking about your pathway analysis of how to collect this data, and spending a bit of time thinking about how to do that. It was just a case of time frame really with this project. But we were able to get some, and in the full report, which we'll link to in the chat, you can see, I mean, essentially, I think we've struggled to get the demographic information, but we were able to understand kind of people that were entering the caseload and numbers donated, which was a relatively high percentage. And we were understood, I suppose, from it that most people enter the pathway, have their initial healthcare screening, and it's at that point where there are large dropouts. But generally, once people progress through the pathway, it has to be for a really good reason that people tend to not end up donating. So that does impact when we're thinking about some of the changes that are made and suggested around condensing appointments. The other really important element of this was lived experience, and making sure that once the pathways had kind of been described and the staff that work really closely in terms of what this looks like, that we then spoke to people who'd gone through the donation experience and said, does this match your experience? What was positive? What could be improved about it? What was the kind of social impact on themselves, their families, their carers, their work life? And were there any kind of access or equity issues that came up? So we did some semi-structured interviews. We recruited one person from each site, again, largely due to the timescale of the project. In terms of how we did this, it was kind of those interviews, and then we made sure that that was really accurate, and we had consent for inclusion of kind of what people talked about and whether that was truly represented in the report. And we've also we'll go through the tools in the document in terms of doing this in your own service, but provided some guidance and best practice around how to do this in your own service. Main things to highlight from the feedback were, of those we spoke to, I think that the things that really struck out were that people had done a lot of their own research in order to make the decision to donate. So it kind of raised the questions of how we're supporting people who don't have access to that information potentially. It certainly raised the importance of face-to-face contact. Virtual contacts might be appropriate for some appointments, but certainly not for all. And really donor choice is key. So when we're thinking about kind of what we might think about sustainable switches, actually we need to think about what's appropriate for people. Condensing and reducing the number of appointments was generally seen as positive, and that can have really positive impacts on people from a social perspective, not having to travel as many times or taking so much time off work. And then acknowledgement about different views of transplant in different communities may impact who's coming forward and how more work could be done with communities around education, around donation and transplant. But again, kind of all the full details of that are in the larger report. So just a general key takeaways from the initial phase of this project was, as I say, it was a short time scale, and it kind of came down to we worked really closely with the participating sites, but obviously they're really busy, so getting that information out so the average, as Rosie said, living kidney donor assessment pathway carbon footprint is 114.2 kilograms of CO2. Donor to travel makes up a significant proportion of this, and just to compare that with dialysis, which is 3 tons of CO2 per year, so actually relatively small in comparison to someone being on dialysis, which is quite significant when we're thinking about that whole patient kidney pathway that we discussed at the beginning. Blood tests and diagnostics are typically the same, because obviously they're kind of standardised of what people need to have. And sites that condense appointments typically have a lower carbon impact, can speed up the donation pathway and provide a better experience for donors. But really what's pivotal is any reduced carbon model, and when we're thinking about sustainability, needs to be balanced with the needs of donors. Because if the pathways become too inflexible, and people's experience are really important in that potentially outweighs the carbon benefits of going through with transportation and having that bigger sustainability impact of the recipients not needing dialysis for a long period. So those were the kind of main key takeaways from phase one. We just wanted to offer, before we dive into the support and the toolkit and the tools that are there to help you do this in your service, if there are any questions about that initial phase, or just any questions at all really about this work. So I'll leave a little bit of space for that. Lisa.
So hopefully I've come off mute and you can hear me.
Yes,
I'm
we
so
can.
sorry. I was trying to do sign language, which wasn't particularly edifying, but at the beginning. Um, so thanks, Rosie. Thanks, Catherine, and thank you for running these webinars. I think that this is really, as we've talked about before, as sort of a continuation of work that we've been thinking about, but not in this way, for many, many years, about how we can streamline pathways. And I think one of the challenges the people have is that not one size fits all. But I think the good thing about this work is that what it describes are different pathways, taking into account the preferences of donors and where they would prefer to be seen, and so on. It also reflects that there are different challenges if you're a more rural centre or a more urban centre, in how people may travel or need to travel, and so on. But what I hope it does most of all is make people just think about their programme specifically in terms of what they can do. And I think we saw with one particular centre that actually reducing, I think, their number of visits by a quarter actually would have a significant impact on the carbon footprint. So I think thinking about it in terms of sustainability is quite a nice driver for the future, around how we make pathways more streamlined and more donor centric, actually. But I think it's really important that we think about it from the donor perspective first, as well as what makes life easy for us. It's about really making life easy for them and manageable for them. So I'm hoping that it takes us to that next level of thinking where perhaps we're not quite where we want to be.
Thank you, Lisa. I can't see any hands up at the moment, but if you do have any questions about that, I'm more than happy for you to put your hand up as we're going through, or pop something in the chat if that's better for you. What we'll do now is talk through the toolkit. So obviously we've just gone through the findings of phase 1. We want people to kind of use that learning and go and do this work in your own services and settings. So we developed a few things that hopefully will be helpful for that. So I'm just going to share my screen and share the toolkit. So Rosie shared with you the link in the chat of how to access this, but do give us a shout if you've got any problems. So I'll just really briefly go through the contents of what's in this toolkit to help you to do this, and then Rosie's going to talk through the carbon tool, which is a little bit more in depth, I think, and is helpful to have an explanation from. So you'll see in this toolkit you've got a couple of resources here around engaging stakeholders. Obviously, if you're trying to do this in your own service, you can't do it alone. You need to involve all the relevant people that are involved in that pathway. So just a little bit of guidance and support around engaging stakeholders, and some best practice around involving people with lived experience. As Lisa just said, it's really about the donors first and what's best for them. So this is really crucial, and to really involve people right from the beginning of trying to do this work. So there's just some guidance there. I won't go through it in detail, but it is there to help you if you want to have a look at that. The third part really is how to map your pathway and resource use. So we've already kind of defined what this is. So the purpose is a pathway mapping exercise, which kind of starts at the point of the potential donor being referred to your service to the preoperative appointment before surgery, and that's the kind of the part of the pathway that we're looking at. We've talked about engaging stakeholders and that being the next step, but then it's about really looking at your resource use. So as I say, I'll hand over to Rosie in a minute to help you look at the tool for that. And then obviously the other part of it is looking at your donor population alongside gaining those lived experience views. So there's a bit of guidance here around questions that you might want to answer about your donor population, and some guidance and support around collecting that information. It's really important, I think, like I said, we had quite a short time frame for the phase 1 to really think about where to get this information and how people can help you do that within your services, and make sure it's information that you can continue to collect reasonably easily as you move forward and try and understand the improvements. What we've also included as part of this tool are some potential high impact changes that potentially have the biggest impact. So we've said that donor travel was the biggest carbon hotspot across the pathway. So a couple of ways to reduce donor travel are condensing appointments, and also looking at switching from face-to-face to virtual where appropriate. And as I said, patient choice and donor experience is going to be key here. So there's just a couple of examples and kind of pointers of those high impact changes that you might want to make. And then also, as part of phase 1, we had some workshops with the donor community to think about other potential improvements, opportunities for improvements across the pathway. And so there's some other things noted there about things that could be explored through trying to do this work as well. And then finally, a case study template. So we are really keen that as a community that people share their work. So if you do the assessment process and make some changes, it would be great if that was able to be shared. So we've just created a really simple case study template and some guidance to be able to share any work that you have done. So there's just some guidance around the best way to do that. So that's the toolkit in a nutshell, and I'll hand over to Rosie now just to look at the carbon element of that in a little bit more detail. Should I stop sharing, Rosie? And
yes, please, and I'll share the tool. Hopefully you can see the Excel spreadsheet.
Yeah, I can see it.
Cool. So to support teams in measuring the carbon footprint of their current living kidney donor assessment pathway, to understand carbon hotspots and measure the impact of any changes made, we've created a pathway measurement tool. This is basically an Excel spreadsheet. I know people probably don't get as excited as I do about Excel spreadsheets, but we've tried to make it as user-friendly as possible, and we're also open to any feedback. So if you think anything could be changed to improve the user experience, just let us know. So I'll go through the tool step by step. So page 1 is just a how-to guide and a step-by-step guide on what tabs to use and what data to input. I'll skip over this as I'm going to talk through it anyway, but it just tells you what data is included in the calculator. So this is a calculator for estimating the pathway from the initial consultation up to the pre-op appointment. We've excluded the surgery itself. So it just includes any virtual appointments, face-to-face appointments, and any water and energy associated with those, donor travel, staff travel, and then any diagnostics, blood and swab tests at each of the appointments. So if we go to the carbon calculator current living kidney donor assessment pathway tab, this is a calculator for estimating the carbon footprint of your current pathway. So on the left you can see all of the pathway elements. So the virtual consultation, the energy and water at the face-to-face, donor travel, staff commuting, and then all of the diagnostic blood, urine and swab tests. And then on the left, we've got a box for each of our contacts. When you first look at it, it can look a bit overwhelming, but we're only filling in the white boxes, and most of these we've tried to make drop down and multiple choice just to make it a bit easier. So I'll go through an example. So our first contact might be an initial virtual contact, so we would just need to select whether it's a telephone consultation or a video consultation. So I'll just click telephone for now, and then we just need to type in how long the call is. So if we just put 30 minutes, and then you can see here that it's estimated the carbon footprint of the activity for us. So if our first contact is virtual, we don't need to worry about filling in any of the other boxes. We can just move on to our next contact. So let's say this contact is face-to-face, we would just choose not a virtual contact in a box and then leave the rest blank. And then we can move on to looking at the energy and water consumption associated with the face-to-face consultation. So for this, you just need to type in the total length of time a donor would spend in a clinic room at their appointment or any scan rooms at their appointment. So you can see if you fill that in, again, it just then calculates the emissions associated with energy and water during the face-to-face appointment for you. The next data point is donor travel. So as donor travel is the biggest carbon hotspot of the living kidney donor assessment pathway, from our report findings, we've given sites two options for inputting data, either using default data or location-specific data. So if location-specific donor travel data is not available, you can use the default data. So for this, you would just need to select the location of the contact, so either at a regional hospital, local hospital, or GP surgery. And then once you've selected that, it will just estimate the donor travel emissions for that contact for you. Or if you're able to get location-specific data, you can fill in this section 2B here. So for this, you would just need to know the average one-way donor travel miles to the location. So you could take a sample of donors, even if it's just a small sample, just to look at, on average, how far away they live from the location. Once you've got this, you could just type in the name of the hospital or location in the box, and then you would type in the distance, and then again it does the calculation for you. The next element is staff commuting. So for this, you would just select the staff member that the donor would see at that appointment, and then you need to write in the number of donors or other patients that that staff member would also see on that day. This doesn't have to be exact, it's just so we can allocate a proportion of carbon emissions of that staff member's commute to the donor. So if the pathway coordinator is seeing 3 donors per day, then the carbon footprint of the commute would be divided by 3. And then finally, for all of the diagnostic blood, urine and swab tests, all you'd need to do is just write in how many of each diagnostic or test is being performed at each contact. So for example, you might have one chest x-ray and then a HLA typing. And again, it just does the calculations for each of those tests for you. This isn't an extensive list of all tests. We just picked the ones most commonly performed and also the ones that we had reasonable carbon footprints for. So the idea is that you would just fill in this data for each of the contacts, and then if you click your results tab, it will come up with the total carbon footprint of your current living kidney donor assessment pathway. And then it also breaks it down into some visuals, so you can see the carbon footprint per contact, and then also you can see the carbon hotspots. If you'd like to make any changes to your pathway, you can remeasure your emissions, so you can fill in exactly the same data on the carbon calculator revised tab. And then once you fill that in, if you go back to your results tab, it will tell you the carbon footprint of your revised pathway, and then you'll be able to see if you've managed to make any savings as well. This is a bit of a whistle-stop tour of the carbon footprint calculator. Like I said, please do contact us if you've got any feedback. Once you've had a play around with it, we're always looking for more ways to improve our tools. I also wanted to quickly mention the staff time tab. So as part of looking at those wider sustainability and quality improvement principles, we also created a tab where you can input the total average staff time spent at each contact along the pathway. And then if you implement any changes, you can re-input the data to see if there's been any staff time savings per donor. That's everything I was going to go through for the calculator. I think, Kath, we've got some time now if anyone's got any questions about the toolkit or any of the tools.
Yeah, we've definitely got a bit of time. So if there are any questions, and I can see there is one in the chat from Richard to Lisa about national guidance and how many hospital visits. Lisa, are you able to answer that?
Yeah, Richard, I was just about to write you a lengthy reply, and then I thought it's probably easier just to talk if we've got a bit of time. So there is embedded in the current BTS RA guidelines, which are housed on the BTS website, and those will be updated, but actually the principles of being minimum number of visits to achieve what you want to do. And many centres have been trying to consolidate that pathway for decades, actually. I mean, Belfast are very much an example of this, where that particular model works very well for them because they have very good linkages with information in primary care, and so they can almost get everything very easily triaged without actually seeing the donor through their primary care history digitally. Other centres prefer to have an initial sort of triage discussion with the coordinator, but then try and consolidate pathways after that. You can't, I don't think, prescribe, because that's wrong, because every centre will want to have a little bit of wriggle room, but the principle is minimum number of visits for what you need to do and what meets the donor's requirements. And I think part of it is trying to consolidate that day of routine testing. What can you do all on the same day? And what's the most efficient with the resources that you have for your pathway. But what I hope this will do is to be able to give a little bit of grist to the mill. If you say, well, actually, we really want to be as sustainable as we can with our living donor pathway, but we have to book all of these tests on separate days because we can't seem to achieve in our hospital this consolidated day of testing. And that may give you a little bit of drive with within your trust or your hospital. I did just want to comment, Rosie, separately, and Catherine. I hope that sort of partly answered the question that Richard had. But actually, this is quite difficult to find, this toolkit. While you were talking, I was trying to search. I searched on your website, I searched on our NHSBT eSIT website, and I couldn't see any obvious links to it. I could imagine people might give up a little bit. Is there going to be something that's in a very obvious place for people that, because it's fine if they've got this link and it's not blocked, but actually I couldn't link it from a website. We could easily, I think, house it through the NHSBT website, linked to you, for example, but what the plan is for that.
Yeah, maybe, Lisa, we could talk separately about where you think a good place to put it is. It is on our website, but yeah, I appreciate there's a lot on the CSH website and it's not the top thing that's up there. Maybe we could have another chat after.
Yeah, absolutely. I think just for the living donor community, they could go to a place they're used to going to and link through to it. That would be really helpful.
Yeah, that sounds good.
Yeah, definitely. There's another question, Lisa, in the chat from Rachel, but I guess I don't know if that, I suppose you've just answered that really in terms of a standardised pathway.
You can standardise to a certain extent, but you've got to give people wriggle room, because you can't say everybody can do a one-day visit. In fact, even one-day visit, we put something like that in many years ago at Guy's, but it's not just one day, because you will have to have sequential appointments, and also you have to balance that with the fact that people will need other investigations, and you can't predicate in other specialist services a particular date or whatever for them. So you can certainly consolidate GFR, CT scan, bloods, urines, second stage testing. There's a lot you can do in a single day, and that is already embedded in the guidelines and has been for many years, and we will try and improve on that in the current iteration.
Great, thank you. I can't see any of the hands or questions in the chat at the moment, so I guess the thing from this is, we really want people just to go away and have a look at those tools, and hopefully feel that you can start to have these conversations and use them in your own service. As Rosie said, we are here if people have questions following you know, perhaps you go away and have some conversations and have a look a bit more in detail, and then the questions come. So please do get in contact with us. We'll pop our emails in the chat. But I think we've got a few slides to wrap up, a few more kind of resources to share. So if there aren't any further questions, I'll just get those up now. I can't find them. Sorry, bear with me a moment. Oh, it's gone right back to the beginning. Okay. So just to say that obviously in terms of following on workshops, today is that first one, an introduction to the project overall and overview of the tools, but there are going to be 2 subsequent workshops. So workshop 2 is around exploring proposed changes and measuring impact. So that'll be another opportunity to look at that measuring impact tool and any kind of questions or help you might need with that, but also what changes you can or are struggling to make in your own pathway. So they'll be held, so it's the same workshop, but it's happening twice. So on the 8th of July and on the 16th of July. So I appreciate the 8th of July is quite soon after this one. But the 16th of July, hopefully some of you can make that. And then we haven't got a date at the moment, but hopefully in the sort of early autumn, we'll have another workshop around sharing outcomes and learning. So hopefully people have been able to implement some of this, or at least be able to share kind of what's gone well and perhaps what's been a bit more difficult. So we'll release that date close to the time and keep everyone up to date with who's attended this call. Rosie, you're okay to explain this one? Because I know.
Yeah, I just wanted to give a shout out to the newly launched Environmental Sustainability in Transplantation group, which focuses on making transplantation greener. So you can get involved by being a champion, and the group will be looking at clinical pathway analysis and dashboard creation. So do email the address on the slide if you'd like more info or would like to be involved.
Thank you. And then just to note that at CSH we have our own network platform and resource library, which is a wealth of knowledge, not just in kidney care, but in sustainable healthcare overall. So I really recommend, if you're not already, to join that network platform. There's just so much resource on there, but there is a separate kidney care sustainability network, and a huge amount of kind of resource and information on there if you're not already joined up. So that QR code will take you directly to that. And lastly, just thank you, for joining us this session today. Again, if you have any questions, please don't hesitate to get in contact with us. We hope you'll be able to join us for those 2nd and 3rd workshops as well. And we will send, Rosie, we can send everyone who's on the call the slides.
Yeah, and the recording as well.
And the recording. So yeah, just a huge thank you to everyone for joining, and Lisa for your expertise as well. And hopefully see some of you again soon.